Our next presentation is going to be evaluation and treatment of pseudoaneurysms and arteriovenous fistulas. And for this session, we're going to go over the findings and criteria that we use to identify pseudoaneurysms and fistulas. And that will lead us into a discussion of treatment of pseudoaneurysms with thrombin injection. And we'll talk about some of the issues associated with the use of thrombin, as well as the potential complications of its use. And I guess most of you know that the use of thrombin for the treatment of pseudoaneurysms is an off-label technique, so that's something that should be noted at the beginning. Okay, well, most of us are familiar with pseudoaneurysms. Most of the time they're iatrogenic, usually related to some type of procedure. The incidence tends to be increasing due to the use of larger catheters and more complex procedures and the concomitant use of anticoagulation. And of course, we want to make the diagnosis early to avoid some of the potential complications that may occur. When we talk about femoral artery injuries that we might identify after catheterization of the groin, most commonly we'll see evidence of hematoma, which may be small or very large with collections of blood. Obviously, next common problem we'll identify is a pseudoaneurysm. We may see an AV fistula, and less commonly we'll see evidence of arterial dissection or occlusion. Of course, these patients may present because they have groin swelling and pain. These things may get complicated by underlying infection. There may be compression of underlying structures, particularly the femoral vein. If there's a case of a large arteriovenous fistula, that potentially can cause lower extremity ischemia and congestive heart failure. So as we all know, a pseudoaneurysm is a vascular mass that is connected to the underlying femoral artery by a tract or neck. The blood that escapes is confined by the surrounding soft tissues and hematoma. And again, usually we should be able to identify the neck or the tract. That's the hole in which the arterial wall is disrupted and allows blood to escape under arterial pressure. Here's a pretty look of a pseudoaneurysm using B-flow. It shows us nicely the hemodynamics of the pathology. Again, the blood is confined by the surrounding tissues. And again, we typically will make this diagnosis following femoral or groin catheterization. Less commonly can be related to violent trauma or underlying infection.
I'll be talking about non-atherosclerotic carotid disorders and imaging of these disorders. So when we're thinking about carotid pathologies, we have to sort of know what atherosclerosis looks like in order to understand what non-atherosclerotic diseases are. And so, as Marcia went over before, when we are talking about plaque characterization, we say things are homogeneous or smooth, heterogeneous, irregular, calcified plaque. But basically, we see plaque, and this is what it looks like. There are high-risk features to plaques, as Marcia talked about, and these are areas that are heterogeneous with hypoechoic areas that can represent soft plaque. And although Marcia said she doesn't like that word ulceration because it's pretty nonspecific, I do think there are some plaques that clearly are ulcerated, particularly ones like this where you can actually see color flow within the plaque itself, and these tend to be higher risk. And so this is the typical appearance of atherosclerotic plaque and atherosclerotic carotid disease. This is images taken from a 90-year-old woman. And we can see on this grayscale cine here that there is heterogeneous, calcified, irregular, shadowing plaque. Lesions tend to be at the distal CCA, the origin of the ICA. So as Dr. Pollack was saying, they're bifurcation lesions. We see marked velocity elevation at the area of plaque. We see evidence of narrowing at the location distal CCA, proximal ICA. So when do you suspect non-atherosclerotic causes of carotid artery disease? Well, number one, you have to think about the patient who's laying on the bed in front of you. Do they have traditional risk factors, age, hyperlipidemia, hypertension, smoking, etc.? Is the lesion in the correct location for atherosclerosis? If you see a lesion that's in the distal ICA, probably not going to be an atherosclerotic lesion. And then also, is the lesion typical appearing? Does it look heterogeneous or hypoechoic or hypoechoic? Does it look like a focal area of plaque? So here's our first case. This is a 38-year-old woman who presents with a cardiac murmur. She is actually referred for cardiac surgery. And at my prior institution, we used to perform carotid ultrasounds on all pre-cardiac surgery patients. Our first clue that this is that this is a 38-year-old woman. So number one, young age. Number two, young age in a woman. And so probably should be thinking about pathologies other than atherosclerosis. So number one, not sure what happened to the circle there. We're at the CCA origin. And you'll notice this multiphasic appearance here, but also this velocity is 382 centimeters per second, right at the origin of the common carotid artery. This may look familiar to you because Marcia showed an image that looked very similar to this before. And certainly if we saw this type of lesion in a focal way, we could call it plaque. However, we see that it extends along the length of this vessel. And as we lay the proximal common carotid out here, we can see that this lesion goes along the entire wall here. And as we go along the common carotid artery proximal, this is a highly, highly abnormal Doppler image here. Number one, the velocity is very elevated, 501. And this is a multiphasic waveform in the common carotid artery.
I'm Margarita Revzin. I work at Yale. I'm associate professor of diagnostic radiology, and I do a lot of ultrasound. And today I'm going to discuss some challenging carotid cases with you. So our objective is to discuss a role of Doppler in evaluation of carotid plaque that Dr. Pollock described really nicely. So we're going to just show a few examples and get it more visual of importance of the plaque, and then discuss carotid waveforms analysis because it's a window to intracranial and more proximal central thoracic pathologies. And then also we will review some pitfalls and mimics of carotid disease. So again, as Dr. Pollock said, plaque is an independent predictor of carotid vascular disease, and our job is to look at the plaque, see if there is one or not, and also characterize it location-wise, if there is also any kind of intrinsic characterization, provide ulcerations or irregularity and vulnerability of the plaque. So is there a stenosis or occlusion of the CCA or ICA with the plaque? You're looking at your color Doppler images in life, and you can see that there is this hypoechoic area that is within the lumen of the carotid artery, and you wanted to be able to measure this degree of stenosis that's caused by this plaque. Also, if you have a prior examinations, you do want to look at the priors and see if there is a progression of disease or not. And then once you see the plaque and there is a significant narrowing of the lumen, you wanted to put your spectral Doppler right there at the level of where there is the highest level of narrowing, and then measure your peak systolic velocities there. That way you're going to be able to diagnose the highest velocities and then the degree of stenosis. So as you saw from Dr. Pollock's, discussion, there is a damage to the endothelial cells that cause or starts the plaque formation where there is deposition of lipids and cholesterol that later cause inflammation, hypoxia in this area of plaque formation, and then development of neurovascularity within the plaque, and then this area develops some capping of the plaque, and then the hemorrhage within the cap, and then under the cap, and then central necrosis. There is sometimes rupture through the fibrous cap, and that's where the vulnerable plaque develops right outside of it, and then thrombosis formation on the plaque surface is happening as well, and then this plaque that is vulnerable is unstable and can have a high rate of embolization.